I'm definitely not going to go through the whole spiel of the normal lecture that we do during the diving medical course on how do we perform lung function tests and so forth. I'm going to look at the issues of standardization and the changes to standardization that have been introduced in 2019. I think most of the practitioners may not be aware of this update and the new standards for office spirometry. I've got all of these publications that I'm referring to available that I can forward to people. If you're interested, you can just drop me an email. Firstly, if you look at the indications, of course, there are many reasons why we do spirometry. And I think the way in which we do spirometry would be affected by the reason for us doing it. So if you do it for a diagnosis, so to evaluate symptom sign and measure the physiological effects and look at people that are at risk of pulmonary disease, we obviously approach this differently to the one that you'll see at the bottom of the slide, where it's a pre-employment lung health monitoring for at-risk occupations, or to assess the health status before a person do at-risk physical activities. So the difference between diagnosis of a person with symptoms and comparing that to screening, which we do in a person that is totally asymptomatic and so forth. So just some of the things to keep in mind. Of course, the reference to COVID, and that's not the main thrust of this talk. I'll just briefly refer to this, and I've got a few slides in the end if we've got time that I can talk to some of the issues for the concerns regarding spirometry during the COVID period. But in terms of infection control issues, obviously one would look at hand hygiene aspects for the patient and the operator using disposable inline filters. And in the new guidelines, manufacturers are actually required to describe the decontamination procedures for the spirometry equipment and also list the acceptable disinfectants that one can use. So this is a new requirement that came out in 2019. And there's a lot of procedures that you can actually find in the lab procedures manual, and this is the ATS, Pulmonary Function Lab Management and Procedure Manual, which is a very useful document to have if you want to set up your spirometry in your practice. And you can see here the procedures and equipment and filters. So this is the infection control procedures that are described in that manual with all the different things like heat, cold liquid, gas sterilization, and then the normal disinfection that we would typically do in the outpatient type environment. So I'm not going to spend a lot of details on that, but just so that it's there as a reference for you. In terms of calibration, remember that we need accurate measurements. And for the accurate measurements, you have to have calibrated equipment. This must be performed daily, and the temperature, pressure, and humidity is important, and this should be specified specifically. And you can see ambient temperature must be measured with an accuracy of 1 degree centigrade. And volume, as you know, with 3-liter syringe with a maximum deviation of 15 milliliters. This used to be 50 in the previous guidelines. So just have a look. This is now 15 mils or 3%. And obviously you use the bacterial filter like you will do the testing, and you do it at various flows, just the same as that we've done previously. And when you look at the publication that I've referenced there, you can see that there can be quite a significant error in your BTPS factor, depending on, and here you can see we just assume that the ambient temperature is 22 degrees, but if it's not, and there's a change in the temperature in the rooms where you do the spirometry, you're actually going to have some errors in the measurement that we are doing. The same with your relative humidity. If you assume that it is 40%, but the humidity actually changes during the course of the day, then you may need to recalibrate these when you do spirometry. As you can see, the errors there, as well as barometric pressure, as you can see on the graph over there. So the calibration basically requires that you do the measurement with a 3-liter syringe at various flow rates. So fairly slow, flows, as you can see here, inhalation and exhalation, and then faster, as well as some of them fast flows that you have, and then to look at the calibration of volume. And there is a requirement for the new machines, the spirometers, to actually be able to print a report. So here you can see an example of, for instance, a pneumotach calibration report that you can see the maneuvers that have been done there with a 3-liter syringe, as well as a calibration history that is available to show that calibrations have been done. Obviously, when the equipment is calibrated, you can start looking at the diver that you want to do the spirometry on, and you complete the employee details. Age must be completed in years, but also to 1 decimal point. Normally, if you just insert the date of birth, some of these will calculate it automatically. But the latest reference values that are used in spirometry actually uses age to 1 decimal point, height in centimeters to 1 decimal point again, weight in kilograms to the nearest half a kilogram, and then ethnicity must also be included in there. But when it comes to ethnicity, there's potential problems in South Africa, because the move is going to the Global Lung Function Initiative and those reference values that they are using at the moment. And you can see that when you choose on the spirometer the groups, you can choose between Caucasian, Black, Southeast Asian, Northeast Asian, and then other. And when you look at the countries that have contributed to the GLI values, and you can see them listed in this table, you will see that there's some significant gaps in there. So we can extrapolate, for instance, Caucasians and people with European ancestry. You can see they're useful for any person having origins for people from Europe, Middle East, and so forth. They do say that African American equations can be used for individuals from African descent. So you can see the Black population over there. But they do say that there's significant populations that remain missing, and specifically from some of our peoples from South Africa, the colored people in the Western Cape, even the people from African descent. There are not a lot of studies emanating from Africa that shows the normal values for spirometry for the population that we are serving. So one just needs to be very careful in the interpretation values that are used when we use these reference values. Once you've inserted all those information, you obviously need to make sure that the person abstained from certain aspects before you can do the test. So caffeine products, smoking and vaping, 1 hour. Inhaled steroids, you can continue as prescribed. Exercise, we previously just let the person rest for 15 minutes and make sure that he's calm before you do the test. But the new guidelines actually say that you should not do exercise 1 hour prior to the test, because it can significantly affect your spirometry values. And bronchodilators obviously depend on the specific medication. Depending on whether you're using a short-acting beta agonist or a short-acting muscarinic antagonist, LABA or a LAMA. So all of these you can see. So for some of them, the LAMAs, for instance, 36 to 48 hours before you can do a proper spirometry in the person to make diagnosis, etc. Obviously, people requiring many of these medications may not be always considered fit to dive. So we won't have many of these problems, but just once we start making the diagnosis and so forth, just be aware of these withholding times that are required. In terms of the patient maneuvers, this is the same as always. We want the patient, we prefer them to be in the sitting position. And then the exhalation, as you know, is a maximal forceful exhalation until the person is completely exhaled everything. And the number of tests must not exceed 8. Obviously, we don't want the person to bend down and do strange maneuvers that may affect the spirometry. In terms of the quality control, each time the person does a test, an attempt, we need to check for the acceptability criteria after each attempt. And once you have more than one, we look at the reproducibility criteria, as you well know. So let's just run through the newest criteria for an acceptable test. So number one, there must be a good start with a very steep rise. Can you still hear me? Can we just hear whether people can still hear me on?
Yeah, I can hear you, Jack.
Okay. Let me just see whether I can continue. The power just came back on this side, so okay, thank you. Thanks for confirming, everyone. So the criteria for an acceptable test. So number one, there must be a good start. So this is an unhesitating start with a steep rise, and your peak flow must be reached within 15% of your forced vital capacity. So what I normally do is I look at this x-axis and then look at the divide that by by 5, which would give me 20%, and then to make sure that the peak flow is to the left of that mark. So that would then make sure that the measurements, the evaluations that we do on this downward curve are not influenced by a hesitant start. During this downward curve, there must be no artifacts. So we look at cough, early termination, variable efforts, and so forth, an obstructed mouthpiece, no leak or system drifts, and then to make sure that there's complete exhalation. And just note that previously we said that complete exhalation would be for 6 seconds. The new guidelines say that complete exhalation is 15 seconds. That is exceedingly long. And what they are saying is you need to reach the end of test criteria before you reach 15 seconds. So if a person does not reach the plateau, and the plateau is defined as less than 25 moles change in the last 1 second, or if you do it in less than 15 seconds, then you must show that this is repeatable. In other words, I can't exhale for 15 seconds. I can only do it for 5 seconds, 6 seconds, 7 seconds, etc. But then it must be repeatable all the time. Otherwise, the machine should only cut off at 15 seconds, which is quite long. But you would know when you see very ill patients, not the type that we would see in diving, but people with severe obstructive lung disease, they can exhale for 2 days, just they just carry on and on and on. So 15 seconds is the limit there. And then you need to meet the end of forced exhalation criteria. So previously they called this the end of test criteria. It is now the end of forced exhalation criteria, where there's no glottis closure or abrupt end. So this is the flow diagram. So basically the end of forced expiration has got one of these three. So one of those. So have you achieved an expiratory plateau? So that is less than 25 mils in the last second. And when I show you the graphs, what I typically refer to is I say that this is like the plane comes into land. That's how I would describe it. So if that happens, then of course you meet the end of forced expiration criteria. Otherwise, 15 seconds, as you can see there. And if you can't do those, so there's no plateau and you can't do 15 seconds, then we look at the repeatability. And sometimes you will see that in children and so on, so not applicable really to the diving environment. But sometimes people with restrictive diseases, they can only exhale for a very short period, and that may affect them. So this would be an acceptable test. So you can see here on the graph, this is an unhesitating start, a steep rise. This peak that we reach is to the left of 20% or 15% of the forced vital capacity. There are no artifacts on this downward curve, and as you can see, this spirometry flow volume loop actually joins the x-axis. It's like a plane that comes into land. That is the end of forced expiration criteria that we want to see. Some difficulties that one can have that would make this an unacceptable test. This would be an example of a cough on the downward curve. Here you can see the same cough on the downward curves. As soon as you see these, this would not be an acceptable test. Variable efforts that you can see on this slide. The person is not giving a forceful maximal exhalation with each attempt. Variable flow, so again you can see unhesitating start, steep rise, the peak is to the left, but on this downward curve you can see this black line is the one that is considered normal, but in this case you can see this person stopped blowing and then blow, 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 and they started blowing again, and you can see so this is an unacceptable artifact on the downward curve that we cannot interpret. System drift is a technical problem, and that is when you start doing the test, and each test you do, there is just a shift on the way that it is presented here. This is a hardware problem, and it requires servicing or cleaning of the equipment for you to be able to manage that. Poor effort or an obstructed mouthpiece, again you can see the black is normal, so you've got an unhesitating start, steep rise, but then this peak is not to the left of 15 or 20% of the forced vital capacity. So this means that the person did not have sufficient effort, or there's an obstruction in the mouthpiece. If the person doesn't exhale fully, so just let me show you again the plane that lands, or all the acceptability criteria. Unhesitating start, steep rise, the peak is to the left of 15 to 20% of the forced vital capacity. There are no artifacts on the downward curve, and just see here how the plane comes into land. So there's a plateau, and the curve actually joins the x-axis. This is one of the most common problems I see in cases that are referred, is an abrupt end. And it's so easy to spot it. It is when this curve joins the x-axis at a 90-degree angle. So here you can see it, that this curve does not join the x-axis. The plane doesn't come into land, and you can do it at any of these cases. You can see that there's an abrupt end, and the person doesn't fully exhale and meet the end of forced expiration criteria. So here you can see another example. So this person had an unhesitating start, steep rise, the peak is to the left. There are no artifacts, but you can see there's no complete exhalation. This is the way it typically presents. The person just stops exhaling there, and this joins the x-axis at a 90-degree angle. That is not acceptable, because what is going to happen is we're going to start interpreting this and divide the FEV1 by the FVC. And if you look at these values here, the FVC normally, if you do this normally, is 6 liters, but with an abrupt end, it's 4 liters. It's a 2-liter difference in the calculation that you do, or a 1-liter difference. It can be quite significant. So that's why this is so important. And even in this example where you can see that's an abrupt end, and then the dotted line, the normal one where the plane comes into land, you can see the difference between 5 liters and let's say 4.2 liters or whatever. Significant difference if the person does not have complete exhalation. On the volume time curve, you can also see this. So you can see the rise, and then instead of the volume increasing over time as the person continues to exhale, you actually just see a straight line. So there's a flat line, no further flow, the person just stopped exhaling. This is an artifact that is very, very common. A hesitant start, so here you can see the person started exhaling and then again, so these are not acceptable and we cannot use them in the interpretation. This is just the example of excessive hesitance. So while these are in the beginning, you can see these are later on. And this is an example where the person did not give a full blow. You can see that this is a slow start. This peak is not to the left. So if you can see, I divide this by 5, which gives me 20%. So this red dotted line is 20%. We want this peak to be at 15 to 20%. So to the left of this line. And here you can see this is a slow start. Even though it seems like the person is fully exhaling, this is not an acceptable curve that one can interpret. If you have upper airway obstructions, and this is something that we commonly see where the person's tongue gets in the way and so forth, you get this sawtooth-like picture. You can also see this with other central and upper airway obstructions in the airways. So this is also artifacts that we don't want to see on there. So that would be the acceptability criteria. Each time that the person is blowing, we need to evaluate that curve and say, is it acceptable or not? Once we've got multiple acceptable curves, we look at the reproducibility criteria, the repeatability criteria, and we only consider those that are acceptable. We discard all the unacceptable maneuvers. And for reproducibility, we then look at the two largest FVC and FEV1 values, and you can see that these remain unchanged in the new guidelines, 150 mils or 5%. Obviously, if you don't have reproducibility, then you need to continue testing. Just again, when we look at reproducibility, I get this question a lot, and colleagues say, I just need to find 2 that are reproducible. It is quite clear in the guidelines, it is the 2 largest values. You don't just look for 2 that look similar and that. You have to look at the largest and the second largest value, and those 2 may not differ with more than 150 mil or 5%. Of course, if it's not reproducible, you continue testing, but if you do more than 8 tests, then you get muscle fatigue and you don't get the values that we are actually looking for. So this would be a reproducible. You can see a number of tests that have been done over here, and you can see they physically overlap. Unhesitating start, steep rise. The peak is to the left of 15 to 20% of the forced vital capacity. There are no artifacts on the downward curve, and you can see the plane comes into land. There's a plateau that is reached, and all of these look similar. But what we now need to do is to look at the different acts and look at the 2 largest FVC values, and we can see the values here is 5.7, 5.74, and 5.79. So the 2 largest values here, you can see it differs with 50 moles, which is less than the 150. So that's reproducible. For the FEV1, you can see, again, these are the 2 largest values, 4.89 and 4.88. So they differ just with 10 moles, which is less than the 150 moles. So this is a reproducible result with all of the acceptable curves that we've included over here. This one, you can see that the curves are all acceptable. So unhesitating start, steep rise, the peak is reached, there's no artifacts, the plane comes into land, all of that is in place. But once we start looking at the forced vital capacity, 5.6, 6.03, 5.8, so you can see the difference between 5.8 and 6.03, that is actually 230 mol difference. So although all the curves are acceptable, it is not yet reproducible, and therefore one needs to continue testing because the reproducibility criteria have not been met. Just a heads up, if you don't get reproducibility, but you see with each test black, then blue, then red, then green, and you see that it's moving in this direction, it might be that the person is actually getting bronchospasm because of the hyperventilation. So the person is literally getting bronchospasm as a result of the test that we are doing. So then just look at a clinical examination, and obviously the person would then be unfit to dive, but would need management and further treatment and so forth. And that's not an indication to continue hunting for reproducibility. The more you test, the worse it's going to become essentially. So this is the flow chart. So you perform your flow volume maneuver. Once you've done that, you look at each one of them and you say, have I met the acceptability criteria? If it's not an acceptable one, you discard it and you perform another one. If you have something that is acceptable, then you do 3 attempts. Sometimes it's difficult and we stick with 2, but a maximum of 8 per session, as I say. If you've got less than 3, then we continue performing those until we've got 3 or a maximum of 8 attempts. And then when we've got all of these acceptable ones, we look at whether it's reproducible. And if it's reproducible, then we can start the interpretation. Otherwise, we continue performing flow volume loops. The new guidelines require us to actually grade the quality of spirometry. And you can see grade A would be if you've got more than 3 acceptable and they are repeatable. So you can see that is a grade A lung function, and that is typically what we are hunting for and see whether we can do that. B would be if you have 2 acceptable and they are reproducible. C is if you have more than 2 that are acceptable, but they're not reproducible within 150 mil. So you can see that this is something that we would say is not acceptable and reproducible, but we can still interpret the information. It's not like we've got totally no clue of what's going on, and you can see the grading as it carries on here when it's 250 mils and more than 250 mils and so on and so forth. So you can see the grading system for the quality. When it comes to provocation and bronchodilator testing, the principles, of course, here is when we see a diver and they give us a history and say that when they start running, they get a bit of a wheeze, etc. We might be doing spirometry on them that is absolutely normal. But with that history, we might be missing something significant. And we know that the prevalence of asthma in the general population in our area is somewhere around 18%. 13 to 18%. And we might miss a large proportion of people that want to dive, but once we see them, they don't have bronchospasm at that time. But once we do a provocation test, we can actually show that there's a problem. So we can close normal lungs. However, if we see a person and they've already got obstruction when we test them, then the question is whether this is something that we can reverse. So a bronchodilator test. Just remember, you can do a bronchodilator test after an exercise test, but not the other way around. So the bronchodilator would mask the exercise test, obviously. There are a number of provocation test options, the direct and the indirect ones, and the exercise test, I think, is the one that is most commonly used by practitioners in this grouping. The other ones that we use, for instance, at our lung function laboratory that we've got at the hospital could be things like methacholine, direct challenge test, but inhaled mannitol and so on and so forth. When you look at this guideline, you can see exercise is right up there with the mechanisms of getting bronchial smooth muscle contraction and airway narrowing. And then the others further down the line, the hypertonic aerosols like saline, mannitol, AMP, and so on and so forth. So exercise testing really, really effective in showing these pathways and detecting cases. So the exercise test, we normally want people to increase their ventilation rapidly. It takes about 2 to 3 minutes. And then we want to keep them with hyperventilation. And you can see the mechanism here is respiratory water loss with mucosal dehydration, and then the increased osmolarity of the surface fluid, the epithelium and the submucosa. And that stimulus is what gives you the smooth muscle contraction and so forth. So to do that, we want to make them hyperventilate, and there are 2 ways. You can use the heart rate as a proxy. So normally we look at 85% of maximal heart rate for 4 to 6 minutes after these 2 to 3 minutes. So in total, we're talking about 6 to 9 minutes thereabouts that a person is going to exercise. Or you can have 4 to 6 minutes of ventilation that is at 60% of the maximum. So you need to know the maximum voluntary ventilation. or you can multiply the FEV1 by 40, and that would be the ventilation rate that we want to have. Most of us are actually using the heart rate, I think, in the way in which we do it. The inspired air during the exercise test should be dry, and the temperature must be below 25 degrees centigrade. And they advise that you use a nose clip to make sure that the irritation effect on the airways is there. And the objective is to see whether the airways are hyperreactive, and we look at a 12% and 200 ml drop in FEV1. 8% is what one could see as normal, so 10% or more is abnormal. And if you go to 15 or even higher, 20%, that's actually diagnostic. So the specificity would increase significantly. Just an example of a case. So this is a person that was before the exercise. You can see the spirometry looks relatively normal, but the person had a history of bronchospasm during exercise. And you can see in this case, after the exercise, the spirometry actually deteriorated quite significantly. And here you can see the differences pre and post exercise. You can see the FEF 50 and so forth, quite significant drop in the smaller airways. But when we look at the drop in FEV1, which is the one that we're interested in, you can see the measured value in this individual, 2.3 liters before exercise and about 1 liter after exercise. So it's significant drop, 50% drop. And this is more than 200 moles and 12%. So this is obviously diagnostic of exercise-induced bronchospasm. The opposite of that is the bronchodilator test. And here the objective is just the opposite. So 200 ml and 12% increase in your FEV1. And the new guidelines say that you can use a meter dose inhaler with a spacer, or you can even use a nebulization for the patient if that's what you have available. Just a reminder that you need to use a short-acting beta-2 agonist. Otherwise, the effect of the beta-2 would take a long time to manifest. Just note that when you do a bronchodilator test, then the abstinence from bronchodilators is significantly longer. So here you can see the withholding times for indirect challenge testing and for bronchodilator testing. So when you do the exercise test, you can see here your short-acting beta agonist is not 4 to 6 hours anymore. It is 8 hours to make sure that you don't have those effects. So and you can see some of these, 4 days, if you look at Montelukast and things like that, which many of the patients are receiving. So if you're looking at the diagnostic things, then these are the things that one needs to just consider. Again, don't confuse the fitness to dive with screening for occupational diseases. With fitness to dive, we will be happy if a person continues with his inhaled corticosteroids. We even let the person continue with his LABAs and so forth, just to show that the lung functions are stable on treatment, and therefore, while they are on treatment, they may continue to dive. Does that make sense? Yeah. So this is for the diagnostic part of things, of course. So just to show another patient, so this is pre-bronchodilator and then post-bronchodilator. You can see that it normalizes, and we all know this hammock shape with the obstructive defects and so forth. Just another patient of Johan where you can see significant obstructive defect, and then the person gives a bronchodilator, and you see in the FEV1 it changes from 2.35 liters to 4.09 liters, so more than 200 moles, in fact almost 2 liters, 1.5 liter difference, and 74%. So 200 moles and 12% is what is diagnostic. All right, so that's basically the maneuvers that we do. Let's get to the new changes in terms of the interpretation. So we've now done these values, and I see that the FVC is 4.76 liters and the FEV1 is 2.35 liters. So how do I know whether those values that I measured in this individual, whether it's normal or not? So any value that we get, how do we know whether it's normal? So to determine normality, we compare this to the general population. And you can see this tags back to my earlier comment with the selection of the normal population and the normal values that we are going to compare with. So people with similar height, weight, sex, ethnicity, and all these other things that we insert. And from there, we develop the predicted values. Now, traditionally, the predicted values that you see, and here you can see the predicted value for ABC in this individual is 5.38 liters. This is the average value. And I don't know how many of you consider yourself to be average, because once you start differing from average, you are not normal anymore. So the question, of course, is how much can you differ from average? And previously, the classic presentation, or the way in which we looked at this, is we looked at how do you differ from the percentage of predicted values. And we say that if you are within 20%, in other words, 80% of predicted values, more than that, a change more than that would make it abnormal. So the percentage of predicted values, look at your measured value and the predicted value, which is actually the average, and then we compare you to the average value. The new method is that we look at Z-scores. And the Z-score is where we detect a lower limit and an upper limit of normal. So there we look at the measured values minus the predicted value, and we divide it by the standard deviation. So this is what you will see in the latest document, the publications, that the machine actually, the output from the spirometers. As you can see, the FVC, FEV1, it gives you the predicted value, which is the average, but then it gives you also the lower limit of normal, and it gives you a Z-score in the end, as well as this percentage of predicted values. So most of us, when we've trained in diving medicine years ago, you would remember that we've been trained with percentage of predicted values. But the Z-scores, those are the newer ones. And a Z-score basically is that we don't just look at the average of the population, but we also look at what is the variance around that average. So the variation around that average. And when you look at Z-scores, the percentage predicted value would basically just look at this middle value, the average score. But even if you deviate significantly from this, you might still be normal. And that's why we say if we use Z-scores and use a cutoff value of 1.64, basically it would give you a value where 5% of the population would be falling in that value. In other words, the chances that you are still normal with that value is very low. It's 5%. 95% of people must be higher than that value, and this is how you can see it presented in the values. And this applies to all of these measurements. So you can see there's a FEV1 divided by FVC percentage. Previously, we would look at the actual value and say that this value 81, 82, 82.6, etc. This must be higher than 75%. Or 70% if you talk to pulmonologists. But the lower limit of normal, you can see here, is 69.5. And when you look at this, and you look at a fixed value versus using lower limit of normal, we normally use 75 or 70%. But look at persons between the ages of 20 and 40 years old, 20 and 60 years old, the typical divers that we see, you can see many of them, they fall outside of the normal range, even if the value is 80%, the ratio between FVC and FEV1. And this is quite significant, because we only do a cutoff here at a value of 0.75 or 75%. But you can see when you compare this to the variation in the population, it is actually significantly lower already. And therefore, we might be missing a lot of cases because we are using percentage of predicted value rather than using the lower limit of normal and the Z-score, where we look at the actual variation in the population. When we look at the FEV1 and the FVC, so this is significant when you look at the FEV1 FVC percentage. But when you look at the individual values, you can see, luckily we haven't made a major mistake in this, because the ages where we have divers 20, 40, 50 years old, you can see that it's a fairly straight line. But as we are dealing with an aging population, you can see that there's a significant deviation when you look at lower limit of normal and 80% of predicted values. So here you can see 80% of predicted values would typically determine that a person is unfit. Well, in actual fact, it's still part of normal variation. I don't know how many of you, I get a lot of referrals with the diving medical panel with this, where people are seen to have chronic obstructive airways disease. And they seem to develop COPD as they get older. But in actual fact, this is still part of normal variation, and they're still well within the lower, above the lower limit of normal. So just be aware of these changes. And the new printouts from the machines basically gives you these three graphs at the bottom. So it actually refers to this curve that you would see of normal individuals, and then it gives you the Z scores and the lower limits of normal. So this is an example of the printout or the display of one of the spirometers. You can see that we insert the sex, the ethnic group of the person, the date of birth, and all the measurements, height and weight and so forth. We get all of the values that we've measured for the person. But here you can see that this is the reference range. So this is the normal range and the lower limit of normal. And in this case, you can see that the FEV1 divided by the FVC before the bronchodilator is below the lower limit of normal, and post bronchodilator it is still very low and below the lower limit of normal. So that is the easier way to interpret these things rather than using simple percentage of predicted values. So the conclusion, when you look at the new way in which the new latest guidelines are going, is that using the lower limit of normal Z scores and a cutoff value of 1.64, that would be the way to go. We are not using 80% of predicted anymore. We are not using the FEV1 divided by FVC ratio of 75 or 70 anymore. We need to use lower limits of normal to detect whether there's a problem in the diver or not. If you want more details on specific tests and how to do them, quality control issues and so forth, I've just included the reference here for the spirometry lab manual. So this is something you can read online. You can also download the PDF, and this is all available for free download. Just a few words of spirometry during COVID. You would know that the South African Thoracic Society and the South African Society for Occupational Medicine, they've all made position statements on the risks of spirometry, and we've obviously adopted a lot of this, and many people are not doing spirometry for divers, which may become a problem and so forth. But when you look at the SAUHMA guidelines, they say that you can do spirometry if you look at the risk assessment of the persons, and then where you are testing, making sure that there's good ventilation, etc., good disinfection, that you make sure that it's safe to do so. So then you can, in fact, do spirometry. There are a lot of publications in this regards as well. So this is one of them, resumption of respiratory outpatient services in the COVID-19 area. So experience from Italy, where they give some guidance and some solutions. So physical distancing and infection control, how do you protect the healthcare worker if you've got a poorly ventilated room, the contact transmissions and so forth. So a lot of guidelines available in this regard. So I've got some details on how to assess ventilation. If I think, let's first just manage the questions regarding spirometry. But if there are questions and people are interested in how do you set up a spirometry room to make sure that it is safe to do spirometry, then I've got a few slides available for that as well. So I think let me just pause there for now, and then we can take some questions.
Thank you very much, Jack. Thank you for this excellent lecture and refreshing us with the new changes, which is very important to take note of. there were 2 questions from our virtual panel that I just want to get to. But in the meantime, is there anyone on the floor that would like to ask a question? Yes, Smith.
Yeah, Jack, just a comment. I'm not quite convinced about using the Z-score. I mean, it's basically just a way of getting the standard deviations within normality limits. And I understand its practicality in doing a community-wide screening and what is normal, what is accepted. But for an activity like diving, which is the endpoint for me should be, is this safe? So if you're an 80-year-old or 100 years old who's within normal limits for a healthy 80-year-old, is this activity still safe for you? I mean, and I think that's where absolute values would make more sense to me than looking at whether you're just within normal for your age and height.
Yes. Yeah. So obviously we haven't discussed fitness to dive limits and things during this talk, So I purely focused on how do you use spirometry to diagnose abnormalities within a population where a person is asymptomatic, he seems normal. You do spirometry screening and you want to know, the values that I get, how do they at least compare to normal? So I fully agree. You need to look at the bigger picture and look at ability, endurance, and risk. And the effects of immersion and all those sort of things. So fully agree with that, yes.
Great, thank you. Thank you, Jack. Petra just asked how long after 8 attempts do you have to wait before reattempting spirometry?
I can't remember whether they say anything specific in the publication, but my sense is when I read the literature, they talk about a sitting. As 8 attempts, and my interpretation of this is that they say you come back the next day. That's how I interpret it, but I might be wrong. Yeah, I can go back and have a look at that again.
Thanks, thank you. That's how I have it also. But any other questions from the floor or from the platform? Other hands raised?
Yeah, I can't see any hands. So I think if you want to, I can quickly go through the other slides that I've prepared.
Great, thanks, Jack.
Because I actually get a lot of questions around this and how do we assess ventilation. So of course, when you do a ventilation assessment, the first important aspect is that you have to distinguish between ventilation and air conditioning. There are many people that say that I've got ventilation, and I mean, we can hear the things running in the background over here. The question is whether we are now ventilating or just air conditioning. And air conditioning is just recirculating the same air, and it just changes the temperature, but you don't get fresh air in and foul air out. So when it comes to the infection control here, we're talking about TB, and then as an aerosol producing procedure, spirometry, we want ventilation and not just air conditioning. Also, we need to distinguish between positive and negative pressure ventilation, so whether you're sucking or whether you're blowing, and then how much, so what is the number of air changes per hour. But also many people look at this and they've got negative pressure ventilation, they've got sufficient air changes per hour, but they never look at the direction of airflow, and that might still cause a risk. So just to give you a few ideas around these things, so these things that you see in your rooms and so forth, these are air conditioners. It's not ventilation system. So this one you can see it sucks air in at the grid at the bottom, and then it blows it out after it's heated or cooled it down. This does not provide ventilation at all. It simply just recirculates the air. The same with this system. It sucks in and then it blows out at the bottom. It goes through a system where it cools it down, etc., but it doesn't suck from the outside. It actually just recirculates the air. To look at the direction of flow to know whether it is positive or negative flow, we can do a smoke test. This is an example of a smoke test that we've just used a normal incense stick in one of the wards in Tygerberg Hospital. So you see me holding it here, and this room has got positive pressure to the rest of the ward. So you can see that it is blowing the air into the rest of the practice essentially. So this would show you this is positive air versus negative air. There are other things that you can use. There are specific smokers that you can see that are commercially available. But we often just use dry ice, and you throw a bit of water on the dry ice and it makes a little bit of a smoke, and you use these sort of things, etc. In the old days, the old professors that taught me these procedures, they said they just use their cigarettes, but these days you won't be using this. So that's the whether it's positive or negative pressure. The ventilation assessment, to know how many air changes per hour, you actually need to calculate the room volume, and that's fairly easy, length, width, and height. And then you determine the sizes of the ventilation supply and extraction site. So the grill where you actually get the air from or where it's sucked out. And you then measure the flow over that surface area. I just use a handheld anemometer to give an idea. So the supply volume would be, if you look at the supply surface area in square meters and the flow rate in meters per second. So what we then do is we multiply meters per second by meters square, which would give us cubic meters per second. And then I convert that to minute and to hour, and that gives me the cubic meters per hour. And that I can then use to look at the number of air changes in that building. So the air changes per hour be calculated by using the volume of air that is extracted divided by the volume of the room, or the volume of air that is supplied divided by the volume of the room, whichever one is the greater. So if the supply is greater than the extraction, it will give you a number of air changes per hour, but that would be positive pressure ventilation. In other words, it would blow. If the extraction is more than the supply, then that would give you the number of air changes, but it would be negative pressure ventilation because it would be sucking. Does that make sense? So this is an example. So here you can see me on the chair, and this is now a round supply in one of the wards. So here the volume is pi radius squared, and you can see that I have the surface area. I measure the flow rate. You can see over there 4.3 liters, and therefore the volume is the surface area times the flow rate, would give me so many per minute and so many per hour. And then the extraction volume I can get there. So this is the positive pressure, and you can also see with that incense stick that I showed you, this is how we do the calculation. So here I could estimate that we've got more than 20 air changes per hour in this hospital ward room, and you do exactly the same for the room where you will do this. Why is this important? If you want to clear the air from TB or contamination, it can be chemical, bacteriological, or whatever the case may be, the number of air changes per hour would determine how quickly that area is cleared before you can take the next person in. So if you've got low levels, and remember the legal limit, the legal requirement is 6 air changes per hour. That means that you can only take the next person in 3/4 of an hour after this person comes out. So what we've done in our unit, for instance, where we are doing COVID testing at that stage, that was still considered a possible aerosol generating procedure, we've got an extractor fan that is yielding 70 air changes per hour, which means that we can, within 5 minutes, test the person out, and we know it's clear in 5 minutes, next person in, test, etc. And one needs to decide how often do you want to do spirometry in that room where you're doing this, and what would be the number of air changes per hour. And you would typically see that we're looking at 12 to 15, etc. If you look at the time that it takes to do spirometry. So if you go at 15, 20 minutes, thereabouts, to get 99% clearance, I think that's reasonable. So this is typically the advice that I give people, is to say, make sure that you've got 15 to 20 air changes per hour in that room to be safe. The direction of airflow is also very important. So if you are the healthcare worker and you are seeing a patient, you may, for instance, use natural ventilation or extractor fans, etc. The question is, what is the direction of airflow? So if the air is coming from the door across the patient to the healthcare worker, obviously this healthcare worker is at risk, because now, whether you're talking about TB or COVID or whatever the case may be, the direction of airflow is not correct. What you want is airflow away from the employee or from the healthcare worker, so that, and obviously we want to make sure that we don't work when we are ill, because then we can infect the patients. So both of these examples are actually not ideal. And oftentimes I go to practices and I say, why don't you just move things around a bit so that you have ventilation, but that it doesn't cross one of the persons, that it comes from one person to the other one. So for instance, you would close the door, make sure that there's a grid, a ventilation grill in the door, and then put an extraction fan in the window, so that you make sure that you've got consistent airflow, which does not expose either the patient or the healthcare worker. You can now augment this by putting in a screen in between and say this person is going to do spirometry, and everything that is released during the spirometry procedure would be going out via the extractor fan without exposing the employee. So these are the type of things. Now, when you select your extractor fans, you can just go on Google and you can see some of these are very cheap. There's one for 350 Rand that you can put in the typical bathroom sort of thing. Don't just fall for all these things. Make sure that you get the specifications for these things. One of the big problems that we find with extractor fans is fan noise, and even the bearing noise of the fans. And this can be very disturbing if you're busy with consultations and with patients and so on. So I normally say that I want a fan with proper bearings inside, so that the noise levels are less than 65 decibels. That's typically the cutoff that I want to have, which is very, very quiet fan. And there's a few of them that have been installed in our hospital that are working very, very well. So just make sure that you look at two things. You get the volume of the room. Obviously, the smaller the area where you want to do spirometry, the smaller the extractor fan is required. If we want to have 20 air changes per hour in this room, it's a massive, massive fan because of the volume of this room. So get a small area, even demarcated with perspex or something, and then you can have a small fan that is nice and soft, that gives you the 15 to 20 air changes per hour. This is an example of evaluation, so changes in the spirometry room. So there you can see this was a patient evaluation area where I said they need to remove this bench, and you can see here is some supply ducts that comes from the roof, and then some benches. So what I said is the patients can come in through this door, they can sit and do spirometry over there, and we want an extractor fan to the outside over there, and then you get positive pressure from this side, from the healthcare worker area towards the patient. So what I said, these are the ones that need to be removed. Please insert an extractor fan on that side, move the patient to this side, and then the supply is at the side of the healthcare worker, and that would blow away from the healthcare worker and then suck everything out. And you can even put in a screen or something else if you want to do that. Of course, this is not the be-all and end-all, but this significantly reduces the risk of airborne transmission, not only COVID, but TB and other airborne diseases. So you have to do all the other things as well. Make sure that you screen for symptoms. People should wear masks, do proper hand hygiene, put in the physical barriers, do proper hand hygiene procedures and disinfectant in the area and so forth. And then you can do spirometry quite safely in your practice. So I hope that was helpful. Thank you. If there are any questions or comments.
Thank you, Jack. I'm sure that was very valuable to most of us. Are there any questions from the floor? Any further questions from the virtual platform?
Yeah, Cecilia and Jack, it's Phil here. Just to say, in the UK, we are back primarily, despite our very high infection levels, which I think are probably higher than yours per capita. We're back to doing full diving medicals now, pretty much across the entire country. And your talk, Jack, is very enlightening, and I think people have been trying to do exactly what you've suggested in our country to various different effects. I know one guy used to have a small marquee out in his garden, and he ran his spirometry outside most of the time. That was okay during the summer, but is turning quite difficult now. But he's doing his best.
When you talk about summer in the UK, you say the 3 days that you've got sunshine there.
Yeah, indeed. In fact, no, listen, don't be nasty. This year it was 4.
Yeah. No. So I can perhaps just give some comments on using of natural ventilation. So we've got a number of negative pressure ventilation rooms in Tygerberg Hospital, obviously. For the infection control of people that we admit with TB and so forth. And when we go and do those assessments, they normally say that 12 to 14 air changes per hour. And when we go and measure them, they come exactly to that, 12 to 14 air changes per hour. When we do the assessment of a consultation room and you simply open a window, then the number of air changes per hour jumps to 60 to 70 air changes per hour. So it's an order of magnitude larger ventilation volumes that you get simply by opening up a window. So people should not underestimate the importance of making sure that windows are open. And in a place like South Africa where our winter is 3 days full, sorry to tell you that, but in South Africa we can open windows, and in our area on the Cape Flats there's always wind blowing there. So very, very high rates. And as you say, Phil, there's a number of people here also that are doing spirometry through a window. The person stands on the outside of the window in the sunlight and do the spirometry and so forth. So those are very practical solutions as well.
Great. Thank you, Jack. Thanks, Phil. Any last comments, questions? Yes, Dirk.
Yeah, thank you. I understand you mainly focusing on the room for spirometry, but the general matter obviously applies to consultation rooms, to our emergency rooms. And that is there specific South African regulations also that rule these settings and that one could use? Because I'm honestly struggling with that. In our emergency in the public sector, you have your MDR TB, just got the smear back with resistant TB. Then you have a diabetic there, and next to it, the COVID suspect where you still wait for the PCR, and yeah, there's barely now. I'm unfortunately sitting in somewhere in the colder parts of the country. the windows don't open that easily in Bloemfontein.
Yes, so the short answer is yes, and it specifically relates to TB, and I can just share my screen again. So this has this biological agents regulations. It says patients should be placed in a room with monitored negative pressure in relation to the surrounding area, 6 to 12 air changes per hour. So that is has this biological agents regulations that specifically pertains to TB and so forth. So you can see regulations for this biological agent. So there's been a recent update in these regulations. I'll have to just check what the newest ones say, but there are even bylaws and city bylaws and building bylaws in terms of what ventilation in buildings should be, the size. If you want to build a house, the size of your windows and where they are placed, that's all regulated. So the short answer is yes, it is regulated. It is there, and you're right. It's not just for spirometry. So as you can see, that assessment that I've done was one of our pediatric wards. where they've got a lot of respiratory diseases. So we do those assessments for isolation rooms, for wards. And there was, in fact, one of the MED registrars in emergency medicine that looked at ventilation in the ERs in the Cape Town area. One of the important findings at one of the hospitals was, and that's a hospital that had 5 isolation rooms with negative pressure ventilation. 2 of those rooms, when we evaluated them, had positive pressure ventilation because the engineer actually fitted the fan the wrong way around. The fan was blowing instead of sucking. And that's why the regulations say monitored negative pressure ventilation. You have to evaluate it and make sure that it actually sucks and it doesn't blow. Yeah, typical.